the degenerative arthritis, it sets in early in some people, but usually as we age, our joints tend to degenerate, and at some point of time, all of us probably suffer with some kind of joint pain, which might be arthritis. This is all we are going to discuss today. We are going to talk about rheumatoid arthritis, the pathophysiology, and osteoarthritis, the pathophysiology and management, the disease burden in the society, the current options, their limitations, and then we are going to talk about the new anti-inflammatory agent that Cadla has developed probably to combat osteoarthritis. Coming to rheumatoid arthritis, we all are aware, being physicians, orthopedic surgeons, being from the medical fraternity, we all know it's a systemic disorder, not just limited to one joint, but usually it's a polyarthralgia. The etiology yet remains unknown, but the pathophysiology, it all depends on the inflammatory cytokines, inflammatory mediators that go and attack the skin, eyes, lungs, blood vessels. Because the etiologies are not known, we have a fluctuating clinical course. Some people are in remission for a few years, some people develop the acute episodes very frequently. And most of the times, not only the joint problems, it's associated with cardiovascular disease-related deaths also. So it's actually a complex and multifactorial pathogenesis as far as rheumatoid arthritis is concerned. So just a brief, probably there's a video also, an animated video, which will take us through the pathophysiology. But just to brief it, it's the activation, it's a connective tissue disorder wherein we have the antigens in our body are produced, which activate the macrophages, and antigen presenting cells, T cells, are activated. This in turn releases inflammatory cytokines, tumor necrosis factor, interleukins, and this leads to all the symptomatology, synovitis, destruction of extracellular matrix, and the cartilage degeneration also. I'll just like to show the video here.
The pathologic hallmarks of rheumatoid arthritis include inflammation of the joints, particularly the small joints in the hands, wrists, and feet, accompanied by cartilage destruction and bone erosion. Underlying inflammation leads to many of the characteristic signs and symptoms of RA, such as pain and swelling of the joints. Inflammation results from abnormal propagation and activation of many types of immune cells, resulting in the secretion of cytokines and other mediators that sustain and amplify the inflammatory environment. As a key pro-inflammatory cytokine, TNF-alpha, along with other cytokines, activate immune cells, including macrophages, as well as other cells, such as synovial fibroblasts. In a key step, activated macrophages and synovial fibroblasts release pro-inflammatory cytokines, including TNF-alpha, IL-1 and IL-6, and mediators of vascular growth, including VEGF. VEGF is essential to the process of blood vessel proliferation, or angiogenesis, which facilitates an influx of activated cells. These cells contribute to the growth of pannus and sustain the inflammatory cycle. The growing, vascularized pannus develops villous projections that result in better access to the cartilage and bone, and therefore greater opportunity for the activated cells to release damaging inflammatory mediators and enzymes. In the interface between pannus and cartilage, activated synovial fibroblasts and macrophages are a source of enzymes that degrade the cartilage matrix. These include MMPs or matrix metalloproteinases. Thus, activated cells in pannus are key instigators of cartilage destruction. Chondrocytes are the main cellular component of cartilage and normally produce the extracellular matrix. However, in response to stimulation by TNF-alpha, IL-1, and other inflammatory mediators, chondrocytes become activated in the rheumatoid joint. Activated chondrocytes secrete more inflammatory factors and more metalloproteinases, MMPs, which aggravates inflammation and cartilage damage. The cumulative result is irreversible cartilage damage and joint space narrowing. Under normal conditions, bone remodeling involves a tightly regulated balance between bone resorption and bone formation. However, excessive TNF-alpha helps stimulate osteoclastogenesis and bone destruction. In the marrow, TNF-alpha helps stimulate monocyte differentiation into osteoclast precursors. At inflamed joints, in the presence of macrophage colony stimulating factor, TNF-alpha and rank ligand, osteoclast precursors differentiate into mature osteoclasts, resulting in bone resorption. Thus, the direct and indirect effects of the TNF-alpha on osteoclast maturation and activation culminate in focal bone erosions and irreversible joint damage.
The only option we are left with is start early at the stage of synovitis itself. Coming to osteoarthritis, it's not a per se an inflammatory arthritis, but the pain that is followed in osteoarthritis is because of the synovial inflammation. It may be because of the osteophytes that are there, it may be because of the degenerative interleukins and the leukotrienes that are there, the inflammatory markers that are there. So TNF-alpha, IL-1 are the major cytokines involved in osteoarthritis also. Apart from that, we have MLPs which have been implicated. So not going into the details of the pathophysiology, probably we can have a summary. Tumor necrosis factor alpha, interleukins are the major inflammatory cytokines involved, and this in turn is regulated by another molecule which is known as nuclear factor kappa B, which is a transcription factor, and it probably plays a very important role in the immune responses and the inflammatory responses of the body. We can call it a master switch, which when turned on increases the inflammation, and if at all we can stop it from being activated, we can stop the inflammation to start. The disorders which are associated with activation of this factor are rheumatoid arthritis, osteoarthritis, ankylosing spondylitis, psoriatic arthritis. Even the juvenile form of rheumatoid arthritis has been implicated to be developing because of the activation of NF-κ-beta. So, what happens? There is the inflammatory stimuli that is there. It leads to activation of NF-κB. It leads to translocation into the nucleus and activation of encoding inflammatory mediators. Finally, these are released and these cause all the pathophysiology which was shown in the animation, the Banner's formation, the cartilage destruction, and ultimately the bone erosion because of the osteoclastogenesis. So, we can say that NF-κB plays a crucial role in the inflammatory and immune responses, and probably regulation of NF-κB may be helpful in preventing the inflammatory process from starting. So coming to the noble molecule which I spoke about at the beginning of our talk, the molecule is curcumin. The chemical name is diferroyl methane. It's a biologically active phytochemical compound. It's actually, I was just discussing with Dr. Bhaumek, it's called a nutraceutical. It's not actually a drug, but it's something which it's chemical which has been taken out from a herbal source, and the herbal source in this case is Curcuma longa, as we all know, haldi. So it's taken out from Curcuma longa, it has been extracted from there, and it has been found that curcumin is actually the active molecule which acts, and it acts as anti-inflammatory, it is an antioxidant, it's anti-proliferative and anti-angiogenic. There have been trials going on for last maybe 2 or 3 decades for curcumin on different diseases. They say that there are 65 clinical trials with more than 1,000 patients have been completed, and 35 trials are ongoing. And it has been found that curcumin actually acts on NF-κB, and it switches off this master switch, which probably prevents the inflammation from setting in osteoarthritis or rheumatoid arthritis. So coming back to the previous slide, if the curcumin is given as a tablet to the patient or in any form, it prevents the activation of NF-κB, inhibits IKB kinase, which is the enzyme. It prevents its translocation into the nucleus, and it prevents the release of inflammatory mediators. So we've actually switched off the process of inflammation. What is the evidence behind all this? We all actually practice evidence-based medicine. So these are the few study trials which have been done on curcumin. This one is a comparative study between curcumin and diclofenac, and the criteria was disease activity score and ACR by the American College of Rheumatology, and they found that curcumin actually is 52% reduction in the CRP level with curcumin they found. A pilot study was done in Indian Journal of Medical Research back in 1980, wherein 18 patients of rheumatoid arthritis were treated with curcumin, and it was found that curcumin improved joint swelling, morning stiffness, and walking time. Coming to the side effects, actually they also found that it's a very well tolerated drug, and it causes very less GI intolerance. Another trial which was published in Journal of Open Rheumatology recently in 2014, in which 820 osteoarthritis patients were given curcumin for 6 months, and it was found that there was significant reduction of pain, the joint flexibility, the movement was improved, and the overall quality of life of the patients improved after this treatment. 50% of the patients, half of the patients who were on trial were actually able to be off any kind of NSAIDs or any other analgesics. So it was found that curcumin therapy is actually well tolerated, and it reduces the patient's need on NSAIDs and any other form of analgesics. Another study in a journal which was a comparative study between curcumin and ibuprofen, 367 primary osteoarthritis needs were examined, and probably the criteria was a pain score, and it was found that curcumin significantly decreases the pain, stiffness, and functional score in the trials. And it was found that GI tolerable of curcumin was much better as compared to any non-steroidal anti-inflammatory drug. Coming to curcumin monotherapy, 100 patients, this was done in 2010, this research was done in 2010, 100 patients were treated. It was given for 8 months. This shows the duration of treatment also. So you can give it for up to 8 months without probably any significant side effect. And it was found that there was a significant decrease in the inflammatory biomarkers. There was a more than 50% decrease in the pain score, and there was a 3 times increase in the walking performance. In all, we can say it's effective and it's safe for long use also. So this was found out in the study. Another study compared curcumin with diclofenac, wherein 88 patients were randomized and were given curcumin and diclofenac for 3 months. And it was found that as compared to diclofenac, long term the patient had greater pain relief with curcumin, and probably the knee injury score and the osteoarthritis outcome scores were better in the patients who were on curcumin rather than on diclofenac. Now the combination therapy. So it was the trials were given for actually founding the effects of curcumin if it was given along with any other molecule. So it was found that if we gave it with celecoxib, there was enhanced action, there was synergistic effect, and gradually the need of celecoxib got reduced. When it was given with steroids, prednisolone, there was again a synergistic anti-inflammatory action, significant reduction in the joint swellings, and probably because the dose of steroids probably was reduced in the long term, so the side effects of steroids were much less. Curcumin, when it was given along with methotrexate, which is probably a first-line drug in rheumatoid arthritis now, again it was a synergistic action. Again the dose of methotrexate could be reduced in long term, and as the dose was reduced, the hepatotoxicity and hematological toxicities were less in the control group. So we could say that the safety parameters, it was well established that curcumin is generally recognized as safe by US FDA. There were no adverse events even when a dose of 8 grams daily was given for 3 months, and it was free from any kind of side effect on kidneys, liver, CVS even after the long-term use. Occasionally, there were some side effects of mild and transient nausea or diarrhea, which were well tolerated, and probably the dose modification took care of it. So the curcumin, probably it's not yet launched. It's only they're going to launch it soon, and the studies, the pilot studies, show a very favorable outcome with patients on curcumin. There are some limitations. There are always two sides of a coin. So the limitations are, it's a poorly water soluble molecule, so it's poorly absorbed from the GI tract. It's undetectable in the plasma. It doesn't reach. This is for the conventional curcumin. As you all know, I told you it's derived from curcuma longa. So the question is, why can't we take direct curcuma longa? Why do we need a curcumin as a chemical isolate? The reason is because the natural curcumin is actually not water soluble, so it's poorly absorbed, and it doesn't reach the systemic organs and tissues, so efficacy is actually not very well proven. The clinical trials which were conducted comparing the chemical curcumin, the nutraceutical, with the original herb, it was found that to have the same amount of blood level for having the desired effect, it needed almost 12 grams per day of curcuma longa, which practically was very difficult. And even in spite of taking that much amount, the drugs, the studies did not show any much positive results, and the GI tolerability was less. So this is the reason why the curcumin nutraceutical is different from the curcuma, normal curcuma, is because the formulation of curcumin is specifically self-micro-emulsifying drug delivery system. We all know it's a nanotechnology, it's coming up big way, nanotechnology. Because the molecule size is smaller, if they are nano-sized hydrophilic droplets, the absorption is improved, which in turn leads to better tissue penetration and probably better bioavailability in the organs concerned. Again, a study was done on humans, and it was found that the curcumin as a chemical, as an isolate, ensures much better bioavailability as compared to the natural curcumin. Coming to the dosage part, the exact dose, being the herb, it depends, it varies from patient to patient and probably depends on the severity of the disease, the degree of inflammation present, and the response of the patient to the molecule. But on an average, it was found that if the patient has mild to moderate inflammation, 100 to 200 milligrams per day was sufficient. The dose could be increased to 400 milligrams per day in severe cases. So to finish this talk, to summarize, curcumin is actually inhibiting the master switch of inflammation, as we discussed, the NF-κB, which prohibits the release of inflammatory markers, prostaglandins, cytokines, interleukins. Monotherapy of curcumin was found to be effective and safe in both rheumatoid arthritis and osteoarthritis, and the synergistic effects of all the drugs were actually better if given along with curcumin. The GI tolerability was at par with NSAIDs, rather slightly better than them. It can be used along with methotrexate without the risk of decreasing the risk of hepatotoxicity concern. Unlike biologicals, like we have for rheumatoid arthritis, we have some biologicals available. This can be given orally, and orally also it's safe and well tolerated. So, to summarize, we can say it's a suitable option, both if we want to start it as a single molecule or as a combination therapy in the arthritis. So it's an attractive option actually for monotherapy and combination therapy. It's particularly useful in the particular group, like patients who are intolerant to NSAIDs. So you have another option for them who are intolerant to steroids or have some side effects of steroids, have a compromised renal function or hepatic function, or are having some cardiovascular disorders like hypertension or heart failure. So it's effective, safe and well tolerated treatment option. So as we all know, movement is life and life is movement. Let's make the life pain free and let's try arthritis at the initial stages before the inflammatory process sets in. Let's stop it at the stage of synovitis rather than let it develop, let it grow till bone erosion or cartilage damage. Probably we all can work together and decrease the disease of burden that we have in our society with some novel molecules like this. Thanks a lot for the patience.